you my slides, and then we can just go through it all. Right. So can everyone see my screen? Okay. If anyone can see my screen, then that's helpful. It just tells me I'm on the right track. Has anyone got a PowerPoint screen in front of them?
Yeah, I can see it.
Great. Okay. So, if it flags up anyone's trying to join this evening, could someone else admit them? Just because I'm not sure if I can admit them if I'm on a different screen. So if you see someone trying to muscle their way in, then please be kind and admit them. Right. So your exam, there's a written exam and a practice exam. Practice exam consists of 2 stations. There's a medical and a trauma scenario. So medical scenario might consist of anything from a heart attack to asthma, anaphylaxis, low blood sugar, stroke. A trauma scenario is going to involve head injury, C-spine injury, chest injury, abdominal or pelvic injury, using the traction splints, etc. And you've got to pass both those stations, and then you've got to sit a theory exam, which has got a 60% pass rate, and that's been confirmed to be the pass rate for this year as well. Off the top of my head, the written exam is approximately 1 hour in duration. And then if you pass all 3 components, you can move forward. There are some errors that you are allowed to commit, which will allow you to resit either the medical or trauma scenario later on the same day. So if you make a slight blunder on the medical trauma scenario and the examiner feels that it was not worthy of a pass, then you'll have the opportunity before the day is over to resit not the same scenario but another scenario of either medical or trauma, whichever one it is was you failed. There are some errors that may be deemed, if they're deemed by examiner to be deemed to be directly harmful by doing something sort of that would be actively harming a casualty, which puts you as an outright fail, and you're not allowed to resit the same day, and you have to wait. I think it's a year before you can resit the exam. I'm not aware that that's ever happened, and with good training that should easily be avoided. Generally, people just require the 1 episode, or they may, on the second rerun, they may make a marginal error again, which means they have to resit the exam without the 1 year delay. But it is theoretically possible that a seriously harmful fault may mean that you have to defer it for a year. I'm just letting you know, just as that's what I've come to understand from going through the syllabus. The practical exam, so the 2 stations, you're expected to do a primary survey, come up with some form of a diagnosis, and then make an appropriate action plan. You may be asked to demonstrate some skills such as drawing up and administering intramuscular drugs, connecting a nebulizer, oxygen cylinder. All of the skills that are on that core skills sheet that you should all have a copy of. They are ones that you may be asked to demonstrate throughout the course of the exam. Obviously, the ones that aren't going to happen. Obviously, the ones that aren't going to be asked to do is things like putting someone in a vac mat, because that's just going to take some time. Just because I'm flitting between screens, if anyone wants a question, just unmute yourself and ask a question. That's absolutely fine. Just because it makes it a bit easier for me to navigate my way through it. So how to pass? So this would be my key to success, which is essentially it's all about the primary survey. So as soon as the examiner sees you make contact with the casualty and start to run your primary survey, they'll know very, very quickly whether they're going to sit back and relax, and they're going to allow you to guide yourself into a pass, or they're going to know very quickly whether or not you're clearly quite rusty, and they're going to have to watch you like a hawk throughout it. It makes a really slick primary survey just makes everything so much more simple. It reduces the stress on your head because you're not having to think so actively throughout the course of the primary survey, and it puts your examiner at ease. So I can't emphasize enough how important it is to have a really slick primary survey. Probably one of the most important aspects. Don't administer drugs without asking for a drug card, and while we're at it, don't administer a drug without asking for an allergy of the casualty, and also take your time. There is a time limit, but it's about 15 minutes, and it's actually quite manageable. So just take your time, don't get stressed, and work your way through in a very systematic way, and you'll be fine. I don't know if everyone's got a copy of the syllabus. This is the syllabus for those of you who don't have it. The date is old, but it still remains the same, and it's a pretty hefty document, and it shows all the skills and bits of information you're expected to know. It's quite nauseating to read just how much there is there, but it's useful to flick through. I've sent it to my guys, and if any of the guys who aren't a NUSO want a copy, you're more welcome to have it. And really the purpose of these sessions is to address some of the non-practical skills that may be come across, so that because they aren't taught as often during the practical sessions that we run, so this is an opportunity to go through some of that more waffly stuff that may come up in your written exam. So we may as well just get straight into it. So 2 mnemonics that you're expected to know through the exam. So number 1 is the Chalet Scene Assessment, and the second is Atmist, which is just here. So Chalet is a scene assessment mnemonic, and it's used to sort of try and help a controller help to run a major incident. There is another acronym called Methane, which you may have heard of. Both of these are mentioned in the Cascare syllabus, but Chalet is the one that's really gone into any more detail. What it stands for is casualties, hazards, access, location, emergency, and type, as it's all listed out in front of you. It's all relatively straightforward. This isn't something that you would expect necessarily to be doing in a practical exam. Well, it's not actually, but it's something to be aware of for sort of practical skills if you end up taking on more leadership roles. But secondly, for your written exam, although you wouldn't be expected to know the real ins and outs of what does every letter mean. Well, actually, I say that. I seem to remember that there may have been a question in the past where it does give you a list of words, and it asks what the acronym stands for. So it would be worth just being aware of that. It's going to be one of 3 acronyms, unfortunately, you've got to memorise, because obviously there's Chalet, there's Atmist, which we'll get onto in a moment, and then there's also your sample, which will be part of your primary survey. So this is something to have down in your sort of cheat sheet, if you like, in terms of revision, just to have an idea of an awareness. So, you know, casualties, we want to know how many casualties, what degree of injuries there are, and what sort of kit might therefore be required. Hazards, so that's hazards to present casualty carriers that are going to be accessing the area, or ongoing hazards to the casualties themselves. What access routes there are, whether that be by land, by water, by air. The location of the scene, you know, what one would hope with a grid reference. And then emergency, so that stands for sort of what services are actually there. Are the paramedics? Is it just mountain rescue? Do you need other more specialist teams or equipment there? And then type is a bit more of a generalized description of the event that's happened. AtMist, so this is a tool that's quite useful to be able to hand your casualty over from your care to the care of someone else. That may be to the care of another casualty carer, or it might be to another service like the ambulance service. So it's actually not unreasonable that this may crop up in real life. Anytime you're a casualty carer, if you're a lead casualty carer, it's expected that you'll have to hand your care over to your patient to another service, and unless you're particularly slick at doing it, this is a nice acronym to use. So A is just basic demographics, so age, name, date of birth. T is for time. M, mechanism of injury, so fall, stumble, sudden onset of chest pain, stung by a bee and has developed an allergic reaction. I is for essentially the findings of your primary or secondary survey, so what injuries have been sustained. And then S, so signs and symptoms, so what the casualty is complaining of, and what abnormal examination features you've seen, so heart rate, pulse, saturations, etc. And then finally T is for treatment given, so you want to be recording dosages of drugs and the time that it's been administered. So that's another acronym to be aware of. And again, this is something that could come up in your written exam. So, any questions so far? So moving on to it's a bit all over the shop this training tonight. I'm afraid it's kind of just trying to get in lots of topics that may come up to try and improve your chances of passing the theory test. So sorry if there's a bit of chopping and changing. So next, we're going to talk about the triage sieve. So again, I don't want to read slides out to you, but the whole purpose of a triage sieve is that if you attend a scene where there's multiple casualties, it's a way of very rapidly assessing the degree of injury and the stability of each casualty, and to some degree the level of survivability of their condition, to be able to quickly rank them into how you're going to prioritize their care, so that you and your colleagues can focus your care in the most efficient way to save the most lives or reduce the most harm as quickly and efficiently as possible. So there's four main numbers. So number one is the immediate. So these are casualties that are generally going to have an abnormality found on your primary survey. So this could be a potentially occluded airway, a chest wall injury that urgently requires oxygen, a hemorrhaging limb which you can reverse by stopping the bleeding, and therefore a small intervention would lead to a significant reduction in sort of harm or death of the casualty. So these are the things we're going to pick up on our primary survey, although that isn't, you wouldn't be doing a primary survey on these casualties. It's a quick eyeball. But when we talk about immediate, we're talking about the types of abnormalities that you'd be looking for in your primary survey. So big, major injuries that you can intervene on quickly to make a big difference. Secondly, we've got our urgent casualties. So these are casualties which, as listed here, are relatively stable. They're unable to walk, but they have comparatively normal physiology. So all the numbers are okay, and you know they're going to need treatment, but they may only need treatment within a few hours. So the next few minutes is not going to make a big difference to them, but the next few hours certainly is. So that's going to be in category 2. Category 3, we're moving on to the delayed category, or the walking wounded. So these are people that you're going to put right on the back burner. So some more minor musculoskeletal injuries or grazes or burns, and this is stuff that you can sit on for several hours if you needed to. So here the definition is 4 or more hours, and you can park them somewhere else safe, and you can relatively safely ignore them. Obviously, the caveat to this is that you need to keep an eye on your triage sieve, because it may well be that things aren't presenting to you in the first presentation, and you may need to re-review. So it's not a case of, oh, well, that casualty is, we're going to put them in the delayed group, we're going to ignore them for 4 hours or more. Ideally, we're going to keep a rough eye on them, and we're going to reassess the status of them, at regular intervals, to make sure that we've not missed something on the first primary survey. And then finally, we've got our final category. So category 4 are expectant casualties. So these are our casualties that have got such significant injuries that it's unlikely that with the resources that are available and the situation that we find ourselves in, that we're going to be able to make any meaningful chance of survival for them. And therefore the difficult decision is made in this situation, that we won't offer them any intervention, and we will unfortunately have to bypass them to go and look after our immediate and our urgent casualties. So here we're talking about really quite devastating injury. So really quite significant trauma, maybe complete evisceration of the abdomen, so the whole of the abdominal contents is hanging out, or there's such significant chest trauma that we're thinking that there's no way that we're going to be able to offer any form of treatment. And there comes a very difficult decision about having to put casualties into this category. So there are colours assigned to these codes as well. So red for immediate, yellow for urgent, green for delayed, so doing a traffic light system, and then blue for expectant, and then black or white for casualties who have already deceased. So here are some examples I've drawn up. So we've got 6 casualties here, and let's have a little talk now about how we might think about prioritising these patients. So I'll just read them all out, so we're going at the same pace, and then if people just want to afterwards just speak out, we're all learning for the same exam, so a bit of interaction would be nice if possible. But we'll then have a think about how you prioritise. Someone got a question? So number 1, male, 10, ankle injury, shouting out in pain, ankles at a funny angle, but his pulse and his nerve in his foot are both fine, and the rest of his ABC assessment is also normal. Next, we've got a female with a head injury who's got some oozing blood. She's alert, conscious, with a graze to the left side of her head, and her ABC is normal. We've now got a female with a head injury who's unconscious, with a snoring noise, with a small amount of blood on the floor. Next, we've got a male with a deep open wound to the thigh with a large volume blood loss. His heart rate is 120 and his respiratory rate is 30. Then we've got a female with evisceration of the abdomen responding to pain. So what we mean by that is that there's been a significant injury to the abdomen, and all the abdominal contents are now outside of the abdomen. and then we've got a male who's got amputation of 2 limbs with catastrophic bleeding, with no pulse palpable, and he's unresponsive. So, who wants to share some thoughts on what kind of casualties we've got here then?
I'd say, hi Patrick, it's Mark. Is the bottom one pretty much dead?
Okay.
Evisceration of the abdomen, I'm thinking that could be your expectant. So I would then go with the catastrophic bleeding for the male deep open wound is the first priority.
Okay.
Mm-hmm.
Then with the female head injury closely behind.
Okay.
And then put the female with the head injury above the male with the ankle injury.
Okay. So you've gone nicely in reverse order there.
Yeah, sorry.
No, not at all. Would anyone challenge Mark's decision?
I would possibly challenge the bottom one. With catastrophic bleeding, you might not find a pulse, but if he's actually bleeding, then the heart's still pumping, and I would be looking at getting the bleeding stopped, possibly. So I put that as immediate. Certainly until we can confirm that there is no pulse, either through a pulse oximeter or whatever.
Okay. What about the rest of it? You happy with the rest of it?
The second one, female head injury, I would park that, but reassess at the second triage. Same with the ankle injury, obviously. Park him immediately, but reassess in the triage, so that you wouldn't forget them for the 4 hours, but certainly park them for a second triage while you're dealing with the third and the fourth, and number 6. Yeah.
Okay. Anybody else who got any different opinions?
The milk isn't too hot that it scrambles the egg.
No. Okay. So I think the question about this patient with catastrophic bleeding. So I guess so. There's probably an error on my part, because you both make a very reasonable argument. So maybe I should have written that, and then sorry, I didn't catch the name of the who spoke second, but would that help you park into Mark's camp?
Yeah, I think so. Yeah, I mean, I read it as there's an ongoing bleed, which would indicate some heart activity, as opposed to a big pool of blood and nothing, no actual bleed.
Yeah, I would agree with you in the sense that it left some ambiguity, didn't it? So if there's still stuff pouring out, then maybe we should try and put something back in. I suppose what we could say in the counter argument is, if we're in this rapid triage setup whereby we've got to make a decision as to what our resources are and what we can do, if we turn off the tap for this guy and we haven't got a pulse anywhere, we're not going to be able to top him up anymore to improve his circulatory system. But I think that for the purpose, and this is why these questions get moderated. So had someone written the question the way I originally labelled it, I think it would be entirely fair to have ambiguity. What I'll do is I'll rephrase it the way I've done it here. So catastrophic blood loss, no pulse or unresponsive, and I think we can all be comfortably singing the same hymn sheet. Is that fair to say?
Yeah.
And then I think we put the next lady in the expectant group. I think that's fair. There's really nothing we're going to be able to do for this lady. There's nothing in our primary survey kit bag that's going to help us put her abdominal contents back into her abdomen. In terms of the next guy, so here we've got this sort of perfect scenario of someone who's got a really acute problem that, if left over a matter of minutes, is going to cause serious harm. So this is really a good way of us breaking off our primary survey, and I will completely agree that this is going to be in our immediate category. And then there's a bit of a debate as to female with a head injury. She's unconscious but snoring. So with that snoring sound, so that's suggesting to us that there's an obstruction to her airway, and I'll go on to that in just a moment. So we think to ourselves, well, wait there. So if there's an obstructed airway, that potentially could be reversible. So then you're left with a slightly difficult situation, as if you're there by yourself, you just got your own pair of hands, then doing one of our head tilt, chin lift, or other manoeuvres, that's going to tie you up then, isn't it? So you can't hold her airway open for the rest of the time. But then what about if we had an airway adjunct with us, and you pop that in, and she responded well to it, then you've made a quick fix that you can move on onto, and there's nothing more you can do about her at the time being. It's her conscious level and her airway that's the issue. So an oral airway would potentially fix that, and you can free yourself up. But if you haven't got an oral airway, you get yourself into this dilemma of, what should I do? Maybe put her in the recovery position if she's lying on her back. So I think there's some debate. And then I would agree that the top two categories are. I certainly think that the female with a head injury with some oozing blood is a relatively clear-cut case, and I would very much support the opinion that she needs a reassessing. And then, interestingly, so this first category is important, because this is all about casualties who can distract you from your job. So we've talked. Some of you may have heard the phrase of patients who have distracting injuries. So they've got a very, very painful part of their body that they're so much pain with that they're not recognizing that they've actually got a really lethal injury elsewhere, and so we don't find that other injury. Now, in this situation, this casualty is being a distracting patient. So that I think it's fair to say that there's no limb or life injury at risk to this casualty, from what we can see. But they're potentially going to drive a lot of attention to themselves, because they're the ones making the most noise, and so it's important that in this triage setup that you remain focused, and you're like, I've seen what I need to see. They are in pain, but at the moment, getting their pain under control is less important than stemming the blood loss from that person's thigh, the fourth casualty, and that's part of this sort of triage mentality. Any questions or thoughts on that?
Patrick, just one question. For the last two, leaving them at level 4, essentially, does that decision also depend on your resources available? Because if you categorise them as a 4, is there a risk you're just going to leave them, and then if you've got enough resource, are you got enough triggers to then go back and reassess them?
So I think that we're saying that probably the last patient is probably dead, with the way that we've reworded this now. So there's no ongoing bleeding. They've had a catastrophic hemorrhage, and we can't find a pulse. So we can't find a pulse. So in normal circumstances, we'd refer to that as cardiac arrest. So we need to start trying to resuscitate them. So we're gonna. I think we'll say that casualty is dead. In terms of the other lady. So this is a difficult decision. Once you've made that assessment, what you are in essence doing is saying that until there's any significant change in your resources that are available, that you aren't going to pay any more attention to that casualty. Now, obviously, if 10, 15 team members or paramedics just rounded the corner and were at your disposal, then you would clearly redirect your resources appropriately. But this is part of the triage shift. It's to work out that you know that in the coming half an hour, that you and one other person are not going to make any difference to that casualty's lifespan. And so therefore, yes, you are essentially going to park that and continue your job until the circumstances change.
Great.
Does that not depend on location as well?
How do you?
Well, on the side of a road by a big car crash is very different to being on the side of a mountain, isn't it?
Yeah. So I think that your triage sieve is dependent on everything. It's dependent on your resources. It's dependent on your geographical location. But I suppose that the mindset of the triage sieve is that you turn up single-handedly with a small kit bag. And you have to make an assessment of a large number of casualties. Now, if you were by a road, then yeah, I mean this casualty will have a higher chance of surviving. But if you still just got your kit bag and you're still by yourself, it's still unlikely that you're not going to make any meaningful difference to their care. Obviously, if more resources arrived and you were going to be able to evacuate them quicker, then your triage sieve might have to be reset up. But the whole purpose is just a quick glance. What's the most amount of impact I can do in the shortest amount of time? If that makes sense. Anybody else have any thoughts or questions on that? Okay, all right. So we're going to, in a not very smooth way, we're going to move away now from our triage sieve and start to run through some rather painful anatomy, because the syllabus wants you to have a knowledge of essentially most of the important anatomy that's required. So we're going to start to go through most of the anatomy that you're going to need to know. So